Now, what we want to do now is hear from you what you think the key challenges are, what are the key shortcomings about HTA as we currently do it, but importantly, we want this to be a constructive discussion. All of the panelists have tried to suggest ways in which we could move systems to be better adjusted to supporting decision-making for sustainable healthcare. So I would like very much to invite people to not just point out problems and issues, but also to suggest constructive ways forward that the HTA community should be embracing, should be working on. Let me just try and pull out some of the themes that I think we've heard from those presentations. Not easy, but actually, as I'm sure you all have noticed, there was quite a lot of overlap in what people were talking about. They were saying it in different ways, they were coming from different perspectives, but actually there was quite a lot in common in what was emerging, and that's very interesting because I think it helps us focus in on some of the things that are important. I think we're all agreed that there's a very important contextual issue here, which is that we're doing HTA in times of shortage. Now, we may be feeling that shortage because we were a rich country which is suddenly feeling poor, or we may be feeling that shortage because we're a developing country which has been feeling poor and is now feeling a little bit richer, but not that richer, and we're trying to expand our healthcare system. But everyone, I think, is increasingly realizing that we are doing HTA in times of shortage. What does that mean for the way we do it, and what kind of HTA do we need to do? I think we've heard a lot, therefore, about HTA and disinvestment. Not only disinvestment that's going to provide resources to do new things, efficiency and many other ways to find savings that HTA may have a role to play in. Be interesting to hear your views on that. Several speakers have talked about HTA and social value, HTA and the political system that sets the parameters, HTA and the legal system, who is actually making the decisions, who should be making the decisions, is HTA feeding into them, should it do it better? So I think the whole set of issues around the context in which HTA is done. I think we've heard a lot about the focus of HTA effort. Is the epidemiology of HTA reflecting the epidemiology of decision making in the health service? I think we're hearing from a number of people it isn't. And what could we do about that? Clearly one thing we can do is talk more to the potential customers, and that's not just the ministry, that's people in the health service, it's people, the patients who are being treated. What decisions would they want support for? And that, I think, brings us to another absolutely key point that's come out of this, is that health technology assessment should not only, or perhaps shouldn't at all, start from technologies. It should start from health problems and care pathways and care questions, to which, of course, technologies provide many solutions, but we should come at it from the questions that the patient and the healthcare maker are making, and that should be the focus. So that's, again, something that's come through a number of presentations here. That brings in a number of things. This would be where we bring in the stratified medicine idea, that if we look at what's actually happening in the health service, these are the kind of decisions that people are facing. Linked to that, a number of people have talked about tailoring HTA to the real context. That's not quite the same thing. We've got to do the right HTAs, but we've also got to do them in a way that people can take them and use them in their own context. Whether it's a hospital which may have a different standard of care from the other hospital down the road, the HTA should be done in a way that is flexible and adaptable enough for people to adapt and use to their own context, whether that's an institution context, a regional context, a country context, or whatever. Then we've heard quite a lot about HTA and innovation. HTA, we must find ways of making sure HTA is judging real innovation, is judging value, and can therefore be used by people to set prices and willingness to pay and all those issues. Are there ways in which we could make HTA more useful for that process? Then a couple of small issues around the way we do HTA at all. A number of people have talked about efficiency. Keep it simple, someone said. Yes, Alexandra. Keep it simple. Collaborate. This is a serious issue around efficiency. A huge amount of HTA capacity around the world is all looking at the same 5 questions at any one moment in time. Do we really all need to look at the same questions? Can we collaborate better? And finally, capacity. Even if we can use our existing capacity better, we still need more capacity. Really interesting point there. Should we be thinking about developing the capacity in the user population before we start developing more capacity in the doer population for HTA? There's not a lot of point in doing lots of HTA which isn't going to get used. So maybe we need to have more of a focus on educating and developing the decision makers and the users to demand the HTA, and then there might be a market response whereby the HTA will flow. So maybe we're putting our effort in perhaps the wrong place in our capacity building, or at least the emphasis. Okay, that's enough of us talking to you. I hope we've set the scene. I hope we've got you thinking. I hope you've heard some stimulating things. I'd like to hear, please, let's have some questions or some ideas or some comments. We don't want this to be a Q&A simply between the panel. Spark off each other. I'll try and keep order, but don't feel that you've got to ask questions to the panel, and I will encourage the panel not all to feel that they have to answer every point that's made, so we can whiz through the points a bit more quickly. So form orderly queues at the microphones, and let's have the first question, please.
Hablaré en español. Siento miedo cuando escucho ETS sin información pública de precios de medicamentos. Pues es como hablar de ETS con efectos, con outcomes secretos. Hablar de ETS sin que conozcamos las facturas de cada venta de medicamentos es como si los estudios de eficacia, es como si las muertes en estos estudios por efectos adversos quedaran en el secreto. Siento miedo cuando escucho diferenciación de precios sin que las facturas sean públicas. Pues lo que yo he visto en los datos es que eso sirve para que los colombianos paguemos 5 veces más que los ingleses. Yo no creo que la sociedad esté dispuesta a cerrar los ojos y firmar un cheque para que luego los políticos y demás decisores, de la mano de la industria, llenen el valor.
Okay, thank you for that point of view. Does anyone want to respond? Laura. You may speak in whatever language you wish.
I'm going to speak in Spanish since muchas gracias por esta observación. Pienso que es muy relevante y realmente la comunidad de evaluación de tecnologías sanitarias ha hecho ella un esfuerzo muy grande en los últimos años para ser transparente. Ha de haber más transparencia, estamos trabajando con ello. Y yo pienso que incluso la industria cada vez más está viendo que si ella no es transparente no va a funcionar. Por lo tanto, aquí debemos colaborar todos, porque hemos de crear lo que los anglosajones dicen win-to-win situations, ¿no? Y para que ganemos todos perderemos un poco y hemos de entender que estamos en un mundo global en el que todos queremos que vaya hacia arriba. Por lo tanto, la comunidad de evaluación hace esfuerzos para ser transparente y para buscar transparencia en sus análisis, y yo creo que la industria también está comenzando a hacer esfuerzos para ser más transparente. Es un cambio cultural, necesitamos todos cambiar la cultura, pero yo creo que estamos en el camino. Pero muchas gracias por tu comentario. Gracias.
Oscar, muito interessante a sua colocação. Eu não sei se eu sou tão otimista como Laura com relação a esse tema. Eu realmente estou bastante preocupado com isso também, tendo já experiência de mais de 10 anos com a questão de decisões sobre preços aqui no Brasil e vendo a tendência internacional, nós aqui no Brasil usamos também preços de referência internacionais, embora o nosso foco da regulação, como eu expliquei, seja a questão da comparação do benefício terapêutico. E cada vez mais eu tenho visto que os preços que nós encontramos, né, nos sítios da internet não são os preços reais, né? Então, outro dia mesmo, conversando com uma colega minha de um governo, me pediu segredo, não posso revelar o nome, mas de um país desenvolvido, que muito conhecido por sua aplicação da avaliação econômica na tomada de decisão, né? E nós utilizamos esse país na nossa cesta de países de referência, né? E eu comecei a notar e era um país que tinha preços baixos há 5 anos atrás, eu comecei a notar que isso tem mudado, né? E num encontro que tivemos, jantando, né, conversando informalmente, eu perguntei, e ela me disse, aqueles preços não são reais. Cada vez mais nós fazemos acordos para descontos que a indústria nos dá. Só que a condição que a indústria impõe é não divulgar esses preços para os outros países, né? Então, se os países aqui representados, se os governos aqui representados, né, não se darem conta de que isso vai contra os interesses de uma sociedade, ele pode ser a curto prazo uma boa solução para aquele governo ter uma economia, mas como sociedade global, nós estamos indo para o mau caminho. Então, nós precisamos que o princípio da solidariedade prevaleça. Pode parecer ingênuo, pode parecer idealista, mas nós precisamos fazer um grande acordo social, mundial, global, para que isso realmente vá para o caminho do acesso, da ampliação do acesso, né? Essa é a minha opinião.
Mic on, please. Thanks. I'm going to ask Jens just to say a few words about this, and we'll close this issue at that point because there's many other issues to talk about. I think it's interesting that as I heard Jens's proposal, he was actually saying that this system is broken, and the view was coming informally from industry that actually the system is broken. I think he also made the very interesting point that if we mend the system by having universal solidarity across all countries of differing incomes, we will inevitably end up in a position, if we don't do something about linking prices to real value in different contexts, we will inevitably end up with a situation where the poorest countries and the richest countries are paying the same price for something which, that's a situation which will also be extremely inequitable in terms of the health gain that they each find in real life. So I think there are not simple solutions to this, but Jens, please.
Yeah, thank you very much for that comment. Unfortunately, and I apologize for that, I cannot specifically comment on the Brazilian situation because that is not within my area of responsibility. What I can speak to is what we have seen in Europe over the last 15 to 20 years. Because in Europe, we have a strong tendency through a common European market to allow trade of pharmaceuticals and other goods between markets, and we have the practice of international reference pricing. What we have seen 15 or 20 years ago was that there was a large variation of prices where Germany, Switzerland, the UK were paying higher prices and countries in Southern Europe or in Eastern Europe were paying significantly lower prices. Through the existence of parallel trade and international reference pricing, those corridors have dramatically been reduced over the last 15 years. We had 50% up and down from the median price in Europe 10-15 years ago. We now have plus minus 10%. The economic ability of the markets in Europe is much more than plus minus 10%. So we already see that what I indicated here, the prices are too high in the low-income countries there. Reference pricing was well behaved for a long time, where the countries that were referenced were of equal economic ability. We have seen over the last couple of years, in particular in the wake of the economic crisis, that now everybody tries to reference the lowest price in the world. And as an industry, if we want to protect our ability to invest into research and development, we will not be able to offer the medicines around the world at that lowest price. There has to be a solidarity that higher income countries pay higher price in there. So I would encourage you here in Brazil, who are suffering from international reference pricing, to stand up and say it is inappropriate that higher income countries are using your prices that we grant you in these markets as a reference for themselves, because you will be suffering from that, because then we cannot allow these prices. When you say prices have to be more transparent, we are trying to work with governments to set up mechanisms that can allow or that can offer you a lower price in your market without that risk of this price being referenced. That creates confidential prices, but in a very transparent process how we arrive at those prices. And that is what we have seen through patient access schemes, through innovative contracting arrangements in many parts of the world. And I think that's the area where we can come to a situation that we expand access and offer you medicines at prices which are in line with your economic ability.
I don't expect we're all going to reach agreement on this at that point, but I think the points have been well aired. Thank you very much to everyone for making the points clearly and with passion. We've got another 20 minutes of discussion before the wrap-up from the speakers. Brendan next, and then all of this queue is after that. So I think now we need to institute a rule, which I should have said to begin with, which is questions are 1 minute maximum, or comments are 1 minute maximum, and everyone's responses are 1 to 2 minutes max, please. Okay, Brendan.
Thanks, Chris. Brendan Carney from Australia. What a comment on non-drug technologies that was raised by Laura, and disinvestment raised by Calypso. From a Euroscan point of view, we recognise the differences, and our toolkit has separate searching and assessment methods for non-drug technologies. And that's because the non-drug technologies consume as much, if not more, than the drug sector in developed countries in healthcare, but they're much more numerous in quantity and their life cycle is shorter. And what I think the challenge there is that we've got to have better mechanisms to assess the introduction of those technologies, such as field trials or other methods of evaluation. Traditional HTAI really doesn't fit well with many of the non-drug technologies. Some of the bigger ones, yes, but I think internationally we've got to develop better methods to assess the introduction of new and emerging non-drug technologies. On disinvestment, I'd be very interested in the Policy Forum's outcome, but several Euroscan agencies have been involved in this area for several years, and I've got to say that the results are not spectacular. It's hard, it's difficult. The technologies identified usually are obsolete or less effective technologies, but they're low-cost technologies by and large because they're at the end of their cycle. And you need many of them to pay for the introduction of a new technology. What I think we need is in innovation is most technology I see cost more and are more effective. It's very rare to see a technology that costs less and is more effective. And that's where I think we need to focus on innovation. Thank you.
Okay, thanks. I'm not sure there's a need to respond to that. I think 2 points. Disinvestment's difficult, and we need better methodologies for non-drug technologies. I think there's 100% support for those points. Thank you for bringing them out. Yeah. Alistair, I think you're next.
Yeah, it's a comment, an observation. The theme of this plenary session is developing HTA for sustainable healthcare systems. What I want to know, somebody said at the start of this conference about NICE that it spends 90% of its effort on evaluating drugs which are less than 10% of the healthcare budget. Why are we not looking more at other areas where HTA can have an input? Why are we not looking, for example, at the 6,000 rare diseases for which there are no drugs, but the people who suffer from them demand action from their healthcare systems? Why are we not looking at whether or not it is better value to employ 1 doctor or 3 nurses? Why are we not looking at how we can deliver end-of-life care for people who don't get access to expensive cancer drugs? You know, the contribution that HTA can make to the delivery of sustainable healthcare is much wider than the evaluation of drugs. I mean, frankly, if the emphasis of this conference is repeated throughout the practice of HTA across the world, I think you might as well rename yourself and call yourself the Drug Technology Appraisal International.
Okay.
You know, it's about health technology, not drugs.
Thank you very much, Alistair. Okay, thank you, Alistair. And I think, to be fair, I mean, that is something which came out of some of the presentations, not as strongly as that, and I kind of summarised. Can I just take 2 minutes? Don't go from the queue. Can I just take 2 minutes to ask anyone if they've got a solution to this problem? What can we do about it? How can we get our systems, focused away a bit more from drugs, or a lot more from drugs? Calypso.
Clarification, I'm not sure it's a solution. I guess the first step is to understand better and for us to communicate better what it is we do. Because I work at NICE, we don't devote 90% of our resources and efforts to technologies. The Technology Appraisals Program is the minority program. We're doing a lot of work on clinical guidelines and pathways, applying very similar principles and following Joseph's idea of a problem-focused approach rather than a technology-focused approach. We've got a big public health prevention program, and we're doing a lot on communicating, getting the information out there, and supporting implementation, measuring uptake. So I guess, and that's our mistake, not having been successful at communicating the fact that we don't devote 90% of our efforts in doing drugs.
Okay, so better communication, but I think we'd all agree there is still an issue there. Even if it's not 90, it's probably more than the 10% we spend on drugs. Laura.
Another idea that I think I point out. Can you hear me? Yes. In the second slide is involve key decision makers. So select appropriately the decision maker who prioritize what HTA should be done. This is key because usually now is scientific professionals, take GPs, take hospital managers. They frame the question of assessment quite differently, and that can help to do HTA. And another, again, I'm advocating for more units of hospital HTA. I think that they are the ones who really knows what's going in there and could really assess procedures, medical equipment, in an organization. I think it's important.
So we need to democratize HTA. We need to bring the people into HTA, and we need to take HTA to the people. So maybe a theme from this is democratization for sustainability. Jan-Arne.
Yeah, and I guess it's about getting the balance right, because HTA cannot, of course, solve all problems of health systems. There are other communities out there, other stakeholders, other researchers, other centers and institutes. But having said that, I think the balance is not right. So I will give Alistair the kind of right in that domain. If you look at the institutions that actually conduct HTA, and analysis from Europe have demonstrated this, is that those institutions tend to get more new roles, and we're actually more look at the whole quality of care picture. And NICE is a nice example of that. There are several similar developments in Europe, in other countries. So I think really to integrate HTA in the larger agenda is important.
Yeah. Great. Bruce.
Yeah, Bruce Duncan, Brazil. I'd like to pick up, Chris, on this question of shortages that you mentioned. And also this question of values. I think one of the main ways that we put value into our work is the definition of the cost-effectiveness threshold. And now that we seem to be feeling a bit poorer than we had in the past, I really wonder if it's not a time to reevaluate what WHO has defined as 3 times the GNP per capita as the appropriate threshold. And I'd be interested in hearing the comments of the panelists on this.
Interesting. Let's get some comments. My own personal thoughts to kick it off is context. A lot of discussion going on in the UK at the moment about there isn't a single cost-effectiveness threshold. Does it make sense to have a single cost-effectiveness threshold even for the UK system? Because actually there's all sorts of different cost-effectiveness thresholds in different parts of the system. So that's just first thought. Other thoughts on cost-effectiveness thresholds and how do we set them and adjust them according to the needs of the political and the overall needs of the system? Any thoughts?
Yeah, I can. Well, I'm sorry, I'm quite skeptical about thresholds. I've always been skeptical about thresholds. I think it could be one indicator, but also we have been talking here a lot about values, social values, and I think that this could be a mix because maybe between a little threshold, but also to take into account the values of this society, of this specific context. And maybe threshold is like one variable else, but values are very important to take into account with that. My personal
I guess there's an issue about, are we looking at a multivariate approach where cost effectiveness threshold is only one of the ways in which we put value into the decision? Maybe there are other, certainly in England, we use a number of other issues which manipulate which modulate the decision around the cost effectiveness threshold. I didn't say that. Right.
In a way, that question is linked to the previous discussion on pricing. Because if you look at the threshold from kind of an international perspective, I think the discussion we just had on pricing is very much trying to work against globalization and free markets. And that's a hard stride, to be honest, to try to work against that. But if we regulate prices and we should have some sort of a formal mechanisms of actually adjusting for purchasing power, and that has really not been taken care of. And that will then, of course, go into the cost effectiveness discussions and thresholds.
Yeah. Okay, thanks. I think we move on. Alvaro, I think you're next, and then Andrew, we're going to go to you with that one.
Thank you. One of the objectives of this session was to know how culture of evidence-based decision-making be promoted across the society. And so I would like to just to say something about what Brazil is doing about that and have the opinion of the panel if it's possible. The Brazilian Cochrane Center is linked to a university, and so we have teaching in the graduation and post-graduation. We give a teleconference course to the health professionals of the Minister of Health, with the support of the Minister of Health, during the last 6 years, and we already had a yearly course to 10,000 health professionals. I understand that if 5% of them became competent, will be very relevant for the country. And in regard the lay people, we are giving a course for people from the legal system, for judges, attorneys, prosecutors, and lawyers. It is a teleconference course nationwide. And we have the experience also that to create the culture of evidence-based decision in the society will be essential, fundamental strategy to improve the HTA around the country and in the world. So we broadcasted already 1,000 TV shows on open channel in prime time. So these are, let's say, interventions trying to expand the value and the relevance of the HTA, evidence-based HTA. I would like to know how you are doing with this process. Thank you.
Thank you, Alvaro. Very, very important and very exciting developments there. I think we had a little bit of talk from the panelists about users, but not a lot of talk about the public, actually, or about those other professional groups who weren't, I think, typically seen as users. We see the users as the doctors and the nurses and the patients, not the judges or whatever. Any comments from the panel? I mean, a very interesting and I think a world-leading development you've referred to there. Any, Jens?
I mean, while you may not be looking for industry as the first kind of area to kind of drive that education, but similar to how we have provided educational grants for continuous medical education, industry is now providing a lot of educational grants for education in health technology assessment, because we have an interest that really all perspectives are heard around the table, patients' perspectives, nurses' perspectives, and in order to feel confident to come to the table, we find that the first part is really to kind of help them get access to that knowledge.
Joseph, I think. Yep.
I absolutely agree with Dr. Alvaro, and that is precisely the reason why in India we are not producing a single HTA report and we're not allowing a single agency to be set up. Because we first want the users, which is stakeholders across all levels, to understand what an HTA report means, what to look for in a report before starting to produce one. In simple terms, we will provide a Ferrari for them to drive when they've learned how to drive it and how to use it on the road, not before that. Thank you very much.
That's great. If I could just add a slightly tangential comment of my own, I think these things are all very important, but I think there's also there are two things that get in the way of what we call evidence-based decision-making in other groups. One is understanding evidence and how to use it. The other is value system. One of the reasons why the legal system doesn't always agree with our HTA and Cochrane reports is because our HTA and Cochrane reports are utilitarian. They are based on the principle that we all agree we are trying to maximize the public good. The legal system is not based on that principle. The legal system is based upon defending the individual's rights to whatever the individual can claim legal entitlement to. And, the way in which these two interact will reflect those two different value systems, however much we educate them. So that's not a reason not to educate, but I don't think we should think that education will immediately bring all these other people into line with a utilitarian point of view. It's a personal point of view. Andrew's been waiting very patiently. He's next in the queue, I think, and then we go back to the right-hand side.
So my name is Andrew Mitchell. I'm from Australia. I wanted to put on this agenda of forward-looking whether we can move from a relatively passive set of recipients to what the evidence is out there to a more proactive, how can we generate evidence that is more persuasive to meet our needs. I think that's something that, particularly in the context of our interactions with the regulatory agencies, I think the time has come, and I think we need to be very clear on what our objectives are and the responsibilities, if we were to exercise that, how to do that in a way that is responsible. The second and related point, picking up on another theme that I heard, which was the idea of integration across technologies as a key thing that's emerging. And I heard it both from Yanan and from Jens. The idea that two technologies or multiple technologies, when used together or in sequence, promotes a better outcome than considered in isolation. And I want to repeat the same plea. When we've looked at the evidence for the linkage, it is extraordinarily underwhelming. It is sparse. It is not persuasive. There is an agenda I think we should be looking at as a subset of the broader agenda if our objective is to move forward with a more integrated model. Comments or anything on that?
Thanks, Andrew. I promised the panel that in exchange for speaking for 5 minutes only each, they'd each be able to speak for 2 minutes at the end to offer their thoughts on what's been said. So I'm going to ask them at this point now to hold back. I'm going to take 3 more points, but please no more than a minute or 2 each, and then we're going to go into the final wrap-up. So please.
Okay, I'll be very quick. Peter Davey from Australia as well. I just want to make a comment and perhaps get some comments back from the panel on this issue of where HTA fits into the healthcare system. I mean, there's sort of 2 broad approaches. One is that it's used at the point of entry for new technologies, and then the other is where it's after the technologies come in. And it just seems to me, from my own experience, that if HTA is used at the point of entry and it's a critical hurdle, decision point, and if the technology doesn't meet that conditions of being sufficiently effective and value for money, then it's not funded. That's a much more sort of powerful place for HTA to be used in the system than where it's used, say, once the technology has already come into the system and more in a sort of guidance type approach. I just wonder if the panel can comment on that.
Okay, I think I'm going to ask them to make any comments they've got in their final wrap-up. So thanks. We'll just take the next 2 points now, and then we're getting very close to our wind-up time.
Yes, Antonio Sarria from Instituto de Salud Carlos III in Madrid. I'm going to be talking in English. So, first, quite briefly, I have always a problem because I see health technology assessment usually as too technocratic, too much concentrated on the issues of how to grade and measure evidence. And in many occasions we know that there are many issues in which evidence is just playing a small part of the decision making, because there's not going to be evidence in which we will support the recommendations that we are going to be making. Second is that I don't know whether this amendment is necessary or not, but we know that in our healthcare systems there's a lot of money that it's not well spent. So, and we need to spend better the money that we have. And there are many examples of things that we are doing that are not necessary, and at the same time, there are many things that are necessary that are not being done because different problems. So, and these kind of contradictions will require a lot of thinking, and of course, I will agree with John on the idea that we need much more information on implementation, on changes, required changes in our healthcare system, because otherwise we are not going to be able, in a situation in which we have been living in many countries, especially in Europe, but of course in Spain, in which the expectation of the population regarding what the healthcare systems can do for the people now are going to be challenged because the financial constraint that we are facing. Sorry about that.
Indeed, very interesting. And our final comment from the audience, please.
Hi, I'm Santiago. I work in Barcelona with Laura San Pietro. Hi. I just wanted to make a comment and a final question to the panel. Well, I'm very short. I'm Spanish, so HTA is a tool for decision making, and we all know that, and we hope it plays a central role in decision making. However, it's not difficult to acknowledge there are other factors that play an important role in decision making. However, the criteria used by decision makers is not always explicit, so it becomes obvious that more transparency is needed. For example, by letting decision makers justify how they got to a particular decision, something which is not usually known to us or to anybody. Ultimately, this information could be very useful to better adapt HTA to the needs of the decision makers. So I would like to ask the panel if there is anything we can do to invite decision makers to clarify the criteria more explicitly, because in my opinion, perhaps the inefficiency we observe in certain public health systems, like mine, for example, in Spain, could be overcome by improving the decision-making process rather than blaming the industry, which seems like a very easy thing to do, but it's not always justified. Thank you.
Thank you very much for that comment. Okay, just to wrap up, as I say, I promised the panellists that they would each get to have 2 minutes at the end where they try and pull out what they think are the key points, not just repeating what they said, or if they wish, repeating what they said, but hopefully responding to what they've heard from the other panellists and you. Joseph had to leave for a plane because we're running a little bit later than we'd originally scheduled. So his point is really to repeat the points which he made, but many of you have made. HTA must become more problem-led, more led by the real problems, solving the questions that decision makers and patients and clinicians have, rather than starting from the problem of what do we do with this new bit of kit or this new drug. So that was Joseph's contribution. I'm going to go this way round. So next is Jens.
Well, thank you very much. I came last, now I can go first. That's great. Calypso started with 2 comments at the end of her introduction, which seemed to indicate that industry is not embracing comparative effectiveness research in HTA. I don't think that is still true. I think we have embraced and have understood that when we want to bring new technologies to market, that we have to meet the evidence needs of payers, of our customers, on the differentiation, and we are incorporating that throughout the development process. The last question was about, are the signals clear enough for us? But we are trying to clarify those signals. I was personally involved in the first pilot that NICE set out in 2007 to have a scientific advice session with the industry before we finalized the phase 3 development program to clarify those approaches. I think that is the way forward. We will still have the problem there that innovation may be considered differently from a manufacturer perspective and from a customer perspective. Customers expect breakthrough innovation. We deliver innovation in small steps. It is unusual to have a Gleevec coming to market. Very often it is small steps that are coming, and we need systems that recognize these small steps. Thank you.
Okay, John Arne, 2 minutes.
Yeah, several of the other panelists, they talked about disinvestment, and that has come up in the discussion as well. I think we could see disinvestment in two different ways. One is kind of disinvestment as a discrete decision related to one single technology, saying that this is used out in the system and now we want to take it out. We need to assess whether to take it out. Really, I don't think that will work, because that's not how the systems work. Disinvestments tend to be kind of done every day by clinicians, and they stop doing things. So the disinvestment agenda is actually about improving efficiency and improving quality. So my message would be that still we need to look at that larger picture. So whether HTA community should do it or whether we should link with others, that's other questions, and I guess that depends on context. But the beauty of the HTA community is that it is building on the culture of evidence-based decision-making, and it links to producers of technologies, to policymakers, to provider organizations, and to practitioners. I am also kind of in other research communities, and those close links to those making decisions are not that good. So I think the beauty of HTA is really the link to the needs of decision makers. And we are kind of getting there, even if we need to improve.
Well, that's good. It's always nice to be reminded we may not be getting it totally wrong, even if we can do it better. I'm beginning to think the HTAI Policy Forum needs to change the title of its next discussion from HTA and disinvestment to HTA and something like disinvestment, which isn't disinvestment. But we'll work on that. Calypso.
Well, I like disinvestment. Anyway, so I just wanted to say that maybe there's an issue about definitions and about perceptions and how we perceive ourselves as well. So I think it's important to maybe work on issues like, for instance, are we only about drugs and new drugs? Are we only about things that evaluating evidence that's already been produced, or can we link to somehow policies that incentivize relevant evidence generation? Is it just the technocratic exercise we're talking about, or is it something broader? So I think the term health technology assessment is rather restrictive. And I'm not saying to change our name or the name of the field, but maybe try and approach it from a different perspective, and maybe have up here, as John Arne said, different types of policymaker and researcher, different types of private industry and commercial interests, because increasingly in countries HTA is being used for, say for instance, incentives to improve quality or accountability that do not have much to do with individual new technologies or pharmaceuticals.
Thank you very much. Laura.
Okay, maybe. Can you hear? Maybe building up of all the things that Hafil already said, maybe the HTA community will have made a big effort during the last years in improving our methods, our transparency, and letting decision makers know that we are there. But maybe we now have to give a step forward and try to educate this decision maker on how to use HTA and making also decisions more transparent. All the efforts we have been doing during all this time, maybe we can help them to make better understand. And also what I said before, that I think we need really to involve people, different profiles of people in defining, prioritizing HTA. And this is quite in the line of what Joseph was saying, that probably these people will let us know we want more problem-oriented HTAs than health technology focus. Thank you.
Thank you very much. And appropriately, our host country and our man from it has the final comment.
Thank you. Eu vou focar nos comentários finais na questão da transparência. E eu vou usar como exemplo, né, e aproveitando algumas questões que foram colocadas sobre por que tanta ênfase em medicamentos. Eu concordo, há muita ênfase em medicamentos, e muitas vezes, quando eu mesmo falo, uso exemplos de medicamentos, e temos que realmente avançar para outras áreas. E como eu não tenho tempo de falar de todas as outras áreas, vou focar na questão dos dispositivos médicos, do medical device. Né? A questão, nesse caso, e aí falando da minha área, né, que é a área econômica, a área de preços, a área de avaliação econômica, a questão dos preços, há realmente uma falta total de transparência nessa. Isso é mundial. Né? E algo realmente perverso, algo realmente muito injusto, quando nós vemos, e nós temos no banco de dados, né, na nossa página, no sítio da Anvisa, informações que mostram que os países ricos têm preços muito menores de dispositivos médicos do que os países em desenvolvimento, os países pobres. Quer dizer, há uma total inversão, inclusive ao contrário do que foi dito anteriormente aqui. Quer dizer, essa é a realidade. E a falta de transparência realmente impede que a gente avance em direção a um mundo mais justo, de maior acesso da população a essas tecnologias. Né? Então, a gente tem que investir realmente em transparência, em aumentar a informação, em trocar informação, em abrir essas caixas pretas que muitas vezes existem. Né? E aí não é só... e eu não estou falando da indústria somente, não. Eu não quis, na minha fala, dar qualquer tipo de direcionamento no sentido de que só a indústria é culpada, coisa desse tipo. Não. O governo também, e quando a gente olha muitos governos, né, no mundo todo, que tomam decisões, né, e as decisões não são transparentes. Né, e as decisões de incorporação de tecnologias no mundo inteiro precisam ser transparentes. É claro que é um processo, é claro que isso não é de um dia para o outro que se faz. Né, e aí, terminando com a ênfase que Laura deu no envolvimento das pessoas, né? Não só apenas no envolvimento das pessoas com a prioridade, a priorização dos temas a serem avaliados como prioridades sociais, né? Mas também envolvimento da população na informação sobre quais são os critérios tomados para a incorporação de tecnologias, né, em cada uma das sociedades. Né? Então a mensagem final que eu queria dar é essa, quer dizer, aumento de transparência, né, realmente direcionar mais para outras áreas que não apenas medicamentos, né? Aumentar a transparência sobre preços, sobre critérios de priorização e critérios de incorporação de tecnologias, né, nos diversos temas de saúde. E o envolvimento crescente das pessoas nesse processo. Essa é a mensagem final. Muito obrigado.
Well, thanks to all our speakers and thanks to all of you for a very stimulating session. We've had a lot of really, really interesting things said about what we could and should do better and how we might do it. Not that many solutions, but quite a few solutions about what the next steps would be, who needs to speak, what could government do. Who's going to do all this? As they say in these kind of business development meetings, if you've ever gone to one of those personal development events, they say, what are you going to do the day after tomorrow? I would encourage all of you to ask yourselves that. The people who are going to make this happen and work differently are you. You are the representatives from government agencies, from industry, from healthcare systems, from patient organisations, from clinical organisations, from the HTA doers and the universities who support them. You can make all this happen. So I would encourage you to think on the plane on the way back home, or the taxi to the airport even, what am I going to do to address some of these challenges? Otherwise we'll be having the same discussion in 10 years' time, and the HTAI conference will be Groundhog Day. So we don't want that. We want to hear next time, or at least in 3 or 5 years' time, how it's changed and how we're doing it better. And that is our responsibility. It's not anyone else's responsibility. We can't just blame everyone and say they should get it better. We are they. So let's go away and do it. Thank you all very much.